Good morning. Today I'll present the data about the Desmoid or aggressive fibromatosis from India. I belong to All India Institute of Medical Sciences, which is in New Delhi. So as all of us know, the literature from India is very sparse. The dedicated centers for sarcoma and desmoid tumors in India is hardly any. There is paucity of new drug trials or prospective studies, and we have very few patient support groups. Also, we don't know the outcomes till now and what the pattern of surgical and medical treatment from India. So here we present our data from 2016 to 2020. Statistical analysis was done by SPSS version 4. Survival analysis was done by Kaplan-Meier curves, and log-rank tests were used for univariate analysis. So the first line treatment or any further treatment is decided in the multidisciplinary setting with surgical oncologist, medical oncologist, pain physician. We don't have radiation oncologists for desmoid tumor meetings or psychologists, but when they are needed, we call them. Patients are informed about desmoid tumors like by education materials, videos, and support group. And we have various videos on YouTube, and we have patient information sheets for this. So many times you take lectures whenever we gather patients and we talk to them about, like in this picture, we were talking about tamoxifen or NSAIDs and their role. So during these 4 years, we had 107 patients. Females were marginally more than males. Median age was 26 years. Age range was to 80 years. Almost 77 patients had diagnosis from outside our center, and of them, 23% of patients had misdiagnosis. Of the misdiagnostic patients, many of them were schwannomas, solid fibrous tumors, and low-grade sarcomas. Most common site for fibromatosis in our patients was upper limb in almost half the patient, lower limb in 15%, abdomen in 15%, and least common site was neck, and multifocal fibromatosis was in hardly 1%. Before presentation to our hospital, almost 61% of patients had been operated. 2.8% of patients had prior history of colonic cancer and were operated for that, and had diagnosis of familial adenomatous polyposis, and it constituted 15% of all abdominal or abdominopelvic fibromatosis. Almost 1/4 of patients had received previous medical therapies, and majority of them were tamoxifen based, either tamoxifen or tamoxifen celecoxib. No patient received sorafenib outside our center. Of 107 patients, 9 patients had no disease and were referred after surgery, and majority of them were referred after one surgery, while 98 patients had disease. So this is the pattern of treatment that was followed in our hospital. In almost 35 in first line, like after they were presented to us, 35% of patients received sorafenib. Tamoxifen was given in 32% of patients. Observation was in 20% of patients, and chemotherapy was in 10% of patients. We consider observation for those tumors which are slow growing, which cause less symptom, or which are in non-abdominal or thoracic or neck side. Chemotherapy was used for those patients who had abdominal tumor causing either visceral complication or patient was overtly symptomatic. In second line treatment, majority of them patients received sorafenib, and tamoxifen was given in hardly 6% of patients, observation 15%, chemotherapy was given in 15% of patients, and in few patients a few underwent surgery. In second and third line, pazopanib was also given in very few patients till now. So as you can see, in first line, no patient underwent surgery in our hospital, which is pretty different when patients had 65% of patient or 60% of patients from outside. And sorafenib use was dramatically increased after June 2018, once this paper of sorafenib was presented in ASCO 2018, while we hardly used tamoxifen-based regimen after that. So this is the progression-free survival. These are the four arms: sorafenib, tamoxifen, observation, and others. As you can see, the sorafenib curve is at top, and there are very few events in sorafenib curve. Tamoxifen and observation are almost overlapping, while others, which is probably chemotherapy, but this subset was very few, 10 patients, and these were the patients who had high volume of disease, rapid progression. So probably in retrospective series, these are not comparable because sorafenib or tamoxifen celecoxib were used in patients who had rapidly progression or over the symptoms, while observation was used in patients who had very less symptoms. And in fact, the median size of tumors in which observation was given was almost 5 centimeter as compared to sorafenib or chemotherapy, which were almost 9 to 10 centimeter. So this is the rate for chemotherapy, median PFS for 15 months. In all lines, first, second, third lines, there were a total of 53 patients that received sorafenib, and in 48 patients, the response was available. The partial response was there in 31%. Partial progressive disease was there in 2 patients, while stable disease was there in majority. So this is the best. This is the best response, and these are the events that happened during sorafenib, and this is the progression-free curve. If you can see, it's almost somewhere in 78% at 2 years, and since we had limited follow-up of 2 years, so it's not wise to go beyond that. However, sorafenib had poor tolerance in our population. 60% of patients had grade 2, grade 3 HFS, for which dose reduction was needed. 400 mg once a day, which was used in NEGM trial, was hardly used in 14 patients, while majority of them patients are on 200 mg once a day. So we didn't have data on beta-catenin mutation till now, but now we are coming up with this data also. This is one of the patient who has abdominal fibromatosis, and we found T41A mutation. Again, we have one patient in which is wild type. So probably we are soon going for mutation testing also. So the summary, I'll summarize this. So median age in our patient was younger. Probably there was inclusion of younger patients. As we can see, there was discrepancy of histopathology in patients who were diagnosed outside, and many of them were diagnosed as low-grade sarcoma. So desmoid is a tumor which is extremely rare, and we need soft tissue sarcoma pathologists or desmoid pathologists for them. Majority of patients who were referred from outside were operated, while medical therapy, including sorafenib, were used in very few. After 2 surgeries, patients who presented to us, hardly any patient was disease-free. Sorafenib had excellent result. However, 400 mg is not the dose which is very well tolerated. We found that tamoxifen-based regimens were less effective and were toxic because almost 12 patients had amenorrhea and we had to stop. Chemotherapy was used in aggressive disease, and observation was used in disease which was too indolent, and the size or the progression of which was too slow, and so they might not be directly comparable. So as of now, we have started our quality of life analysis in AIMS, Delhi, and we are using mutation testing more and more. And we want to collaborate further and learn, and this will definitely benefit the whole community or patient with desmoid, which is our goal. I'm really thankful to our surgical oncology department, pathology department, medical oncology department, and radiation oncology department. Thank you.